A 78-year-old retired engineer named Howard walked into a hospital emergency room in Indianapolis, Indiana, with chest pain and shortness of breath. He was frightened. His wife was frightened. The staff moved quickly, and Howard was grateful for that. In the first 5 minutes, a registration staff member placed a clipboard in front of him. Howard signed where the arrows pointed. He did not read anything. He was focused on his heart. He was focused on staying calm. He did what everyone does in that moment. He trusted the process, and he signed. 3 months later, Howard's family was sitting around a kitchen table, surrounded by bills totaling $23,000, a denial letter from Medicare, and a document that had silently removed their right to appeal one of the largest charges. His wife said, "It took him less than 5 minutes to sign those papers. We are still dealing with the consequences 6 months later. Nobody warned us. Nobody told us there was anything to understand." If you are over 65, or if you love someone who is, what you are about to hear could protect your family from one of the most painful and preventable financial situations that American seniors face today. Not from a disease, not from a medical error, from 5 minutes of paperwork that almost nobody reads and almost nobody understands. Today, we are going through the 5 most expensive mistakes seniors make in the first moments of a hospital visit. For each one, you will learn exactly why it happens, exactly what it costs, and the exact words you need to say to protect yourself before the damage is done. We are counting down from 5 to 1. Stay with me all the way to the end, because the number 1 mistake on this list begins in the very first minutes of a hospital admission, and it is the mistake that sets everything else in motion. Miss that moment, and the financial consequences can follow your family for months. Let us start. The first mistake happens before a single test has been run, before a doctor has examined you, before you have any idea how serious your situation is. It happens at the registration desk, with a clipboard, under fluorescent lights, while you are scared. Hospital intake forms are not simple documents. They look simple. They are presented as simple, a stack of papers that the registration staff member walks you through quickly, pointing to the signature lines, using reassuring language like, "This is just standard, and everyone signs these." But inside that stack, there are clauses that can determine how much you pay, what rights you have, and what legal options your family will have if something goes wrong. We have discussed these forms in detail in previous videos. Today, the important point is this. The 5 minutes you spend at the registration desk are not 5 minutes of formality. They are 5 minutes of legal and financial decision-making, and most seniors treat them like formality. Here is what gets missed most often. Financial responsibility agreements may contain language that holds you responsible for charges Medicare is not legally required to pay. Arbitration agreements may waive your right to sue if you are harmed. Blanket consent forms may authorize treatments beyond what you came in for, and assignment of benefits clauses may limit your ability to redirect insurance payments or dispute individual charges later. None of these are explained at the desk. None of these are flagged as requiring special attention. They are presented as part of a routine that everyone goes through, and in a moment of fear and urgency, that framing is almost impossible to resist. Gloria was 74 years old, a retired bank manager from Sacramento, California. She had spent her career reviewing financial documents. She understood contracts. She was not someone who signed things without reading them. And yet, when she arrived at the emergency room after a fall, she signed everything within 4 minutes. She told her daughter afterward, "I know better. I know exactly what I would normally do with a document like that. But in that moment, I was not thinking like a banker. I was thinking like a frightened 74-year-old woman who wanted someone to help her." The financial responsibility agreement Gloria signed contained language that the hospital later cited when billing her for charges Medicare had partially denied, charges that totaled $6,800. When Gloria's daughter tried to dispute the charges, the signed agreement complicated the process significantly. It took 4 months and a patient advocate to resolve. The family ultimately paid less than the original bill, But the stress, the time, and the emotional weight of those 4 months was a cost that never appeared on any statement. Here is what you need to say the moment anyone places intake forms in front of you at a hospital. Say, I need 2 minutes to identify any financial responsibility agreement or arbitration agreement in this paperwork before I sign. Can you tell me which forms contain those clauses? That request takes 30 seconds to make, and it signals to the staff that you are an informed patient who will read before signing. In many cases, that signal alone results in a more careful explanation of what you are being asked to agree to. If you are in a true emergency and you cannot pause, designate one family member in advance, right now, before any emergency happens, whose only job during a hospital admission is to handle the paperwork. That person is not there to hold your hand. They are there to read every form before it is signed. That division of responsibility has protected families in emergency rooms across this country from financial consequences they never saw coming. Most seniors never make that designation in advance. Most seniors only think of it after they needed it. But signing forms too quickly is only the beginning. The next mistake happens not at the registration desk, but after you are already settled into your hospital room. And most seniors make it simply because nobody tells them there is a question they need to ask. Once you are inside a hospital and receiving care, most seniors assume that the important decisions have been made. The doctors are managing the medical situation, the insurance is handling the financial side, and you are focused on getting better. But there is one question that has enormous financial consequences and that almost no hospital staff member will volunteer the answer to unless you specifically ask it. That question is, am I here as an inpatient or am I under observation status? We have talked about observation status in previous videos, the Medicare classification that designates you as an outpatient even while you receive full inpatient level care. The consequences of that classification are significant: higher out-of-pocket costs, possible medication charges, and the loss of the 3-day inpatient stay required to qualify for Medicare-covered skilled nursing and rehabilitation care after discharge. What most seniors do not realize is that observation status is not always assigned at admission and then fixed. It can change. A patient can be placed under observation status for the first 2 days of a stay and then converted to inpatient status. Or they can remain under observation status for their entire stay without ever being told. And the cost difference between the two classifications can be staggering. Martin was 77 years old, a retired police officer from Phoenix, Arizona. He was brought to the hospital after a serious infection required intravenous treatment. He was there for 5 days. His wife visited every afternoon. The staff was attentive. Everything seemed to be going well. When Martin was discharged, the case manager mentioned briefly that he would need some rehabilitation and that a skilled nursing facility had been arranged. Martin's wife was relieved. She assumed Medicare would cover the rehabilitation stay, as they had heard it would after a hospitalization. At the skilled nursing facility, the admissions coordinator asked for insurance information, and then, after reviewing it, asked a question that changed everything. She asked, was Martin admitted as an inpatient for at least 3 of his 5 days in the hospital? Martin's wife did not know. She called the hospital. She found out that Martin had been under observation status for all 5 days of his stay. Medicare denied coverage for his rehabilitation. The skilled nursing facility charged private pay rates. The bill for 3 weeks of rehabilitation came to $17,400. Martin's wife said, "Nobody at the hospital told us there were 2 different ways to be in the hospital. We did not know there was a difference. We did not know to ask." Here is the question you must ask on the first day of any hospital stay. Not at discharge, not when the rehabilitation facility asks, but on day 1. Ask this: am I currently classified as an inpatient admission under Medicare Part A, or am I under observation status as an outpatient? And if I am under observation status, what is the clinical reason my condition does not qualify for inpatient admission? Ask that question. Write down the answer. And if the answer is observation status, immediately request to speak with the hospital's patient advocate and ask them to document a formal request for physician review of your admission status. That conversation on day 1 gives you options. The same conversation on day 5 gives you almost a none. The clock on this decision starts the moment you arrive. Do not wait to ask. Most families discover the observation status trap after the rehabilitation bill arrives. By then, the stay is over and the options are gone. You now know to act on day 1, but the next mistake happens at the other end of the stay, at discharge, and it costs seniors not just money, but something harder to recover. When a hospital is ready to discharge you, the process moves quickly. A nurse or case manager brings paperwork, reviews instructions, answers a few questions, and the discharge is complete. Most seniors sign the discharge papers and leave, relieved to be going home. What most seniors leave behind, inside that packet of discharge paperwork, is information that could prevent a hospital readmission, protect their recovery, and ensure that the care they need after leaving actually happens. Discharge instructions specify medications, what to take, what was changed, what was added, and when to take each one. They specify follow-up appointments that may have narrow windows, situations where failing to see a specialist within 7 days means starting an authorization process over again, or where a condition can deteriorate rapidly without timely follow-up. They specify warning signs, symptoms that mean your condition is worsening and that require immediate medical attention. And they specify restrictions, activities, foods, movements, and medications to avoid during recovery. When seniors leave the hospital without clearly understanding these instructions, the consequences are predictable. Medications are taken incorrectly or not taken at all. Follow-up appointments are missed or scheduled too late. Warning signs are not recognized. And conditions that were improving deteriorate at home, resulting in emergency readmissions that cost far more, financially, physically, and emotionally, than the original stay. Hospital readmission within 30 days is one of the most common and costly events in senior healthcare, and a significant percentage of those readmissions are directly related to misunderstood or incomplete discharge instructions. Carolyn was 71 years old, a retired teacher from Columbus, Ohio. She was discharged after treatment for a respiratory condition with a packet of papers and a brief verbal summary from a nurse who was clearly managing several patients at once. Carolyn took the papers home, set them on her kitchen counter, and rested. She did not notice that her discharge instructions specified a follow-up with a pulmonologist within 5 days. She did not notice that one of her regular medications had been discontinued during her stay and should not be restarted. She did not notice the list of warning symptoms that required immediate emergency attention. 9 days after discharge, Carolyn's condition worsened. She was readmitted by ambulance. Her physician later determined that the deterioration was likely related to the medication that should not have been restarted and to the respiratory follow-up that had not taken place. Her second hospitalization lasted 8 days. Her combined out-of-pocket costs for both stays exceeded $11,000. Her daughter said, "The instructions were in the packet. Everything was there. But nobody sat with my mother and made sure she understood. And my mother did not know what she did not know." Before you or anyone you love leaves a hospital, say these words to the nurse or case manager handling your discharge. Say, "Before I sign these discharge papers, I need someone to walk me through every medication change, every follow-up appointment and its deadline, every warning sign that means I need to return to the emergency room, and every restriction on my activity or diet." Do not leave until you can repeat back the most critical points in your own words, and ask this specific question. Is there anything in these instructions that, if I miss it or misunderstand it, could put me back in this hospital within the next 30 days? That question has a way of focusing a discharge conversation very quickly. It tells the nurse that you are paying attention and that you understand the stakes. And the answer to that question contains the most important information in your entire discharge packet. Take a photo of your discharge instructions with your phone before you leave. Keep them accessible for the first 2 weeks at home, and share them with a family member who can help monitor your recovery. The instructions they give you at discharge are not formalities. They are the roadmap for your recovery. Leaving without understanding that roadmap is one of the most expensive mistakes a senior can make. Have you ever felt rushed while signing hospital paperwork or making a medical decision under pressure? Tell us in the comments. You are not alone, and your story could help another senior know exactly what to watch for. But leaving the hospital without clear instructions is serious. What comes next can be even more costly, because this next mistake involves what happens after you get home, when the bills and the care decisions start arriving, and when most seniors discover that the coverage they assumed they had is not quite what they thought. After a hospital stay, many seniors need follow-up care, rehabilitation, physical therapy, home health visits, specialist appointments, prescription medications that were changed or added during their stay. Most seniors assume that Medicare will cover these services automatically, that because the hospital stay was covered, the recovery will be covered too. And that assumption, made confidently and without verification, leads to some of the largest unexpected bills in senior healthcare. Here is the reality. Medicare coverage for post-hospital services is not automatic. It is conditional. Skilled nursing facility care requires the 3-day inpatient stay we have already discussed. Home health services require a physician's order and a determination that you are homebound. Outpatient physical therapy may have cost sharing that surprises patients who have not met their annual deductible. Specialist follow-up visits may require prior authorization that was not obtained before discharge. And medications that were provided as part of your inpatient care may not be covered under your Part D plan at the same dosage or formulation you received in the hospital. Each of these gaps requires a specific action to close, and most seniors do not know the actions are required until after the service has been delivered and the bill has arrived. Samuel was 80 years old, a retired minister from Birmingham, Alabama. After a hip procedure, he was discharged with instructions for home physical therapy 3 times per week. His family arranged the therapy. A home health agency sent therapists, and Samuel made steady progress. 6 weeks later, the bills arrived. Samuel's Medicare Advantage plan had not authorized the physical therapy sessions because the prior authorization request, which should have been submitted by the hospital's discharge team, had not been filed correctly. The plan denied coverage for 4 weeks of sessions. Samuel's out-of-pocket bill for those denied sessions was $4,200. The home health agency told the family they had assumed authorization had been obtained. The hospital's discharge team said the family had been responsible for confirming coverage. Samuel's plan said the authorization window had passed. His daughter said, "My father did everything right. He went to therapy, he worked hard, he got better, and then we got a bill that none of us had any way of anticipating." Before you or any family member leaves a hospital following a procedure or serious illness, say these words to the discharge coordinator. Say, "I need written confirmation of the prior authorization status for every post-hospital service recommended in my discharge plan, including physical therapy, home health, skilled nursing, and any specialist follow-up appointments." And then call your Medicare plan directly and say, "I have just been discharged from the hospital. I want to verify that the following services are covered under my current plan, that prior authorizations are in place, and what my out-of-pocket cost sharing will be for each one." Make that call before the first appointment, before the first therapy session, before the home health aide walks through your door. Because once the service has been delivered, the authorization window in most plans has closed, and your options are dramatically reduced. Coverage does not follow automatically from a hospital stay. It follows from specific steps that most seniors do not know they need to take. You now know. Take them before you need them. Now we have reached the mistake that starts everything. The mistake that happens before the forms are signed, before the status question is asked, before the discharge instructions are reviewed, before the follow-up care is authorized. This mistake happens in the first 5 minutes, and it is the most expensive mistake on this list because it affects every decision that follows. It is the mistake of letting someone rush you through the admission process without understanding what you are deciding. Hospital admissions move fast. Emergency rooms are busy. Staff are managing multiple patients. Administrators are under pressure to complete intake efficiently. And in that environment, the natural pace of the process creates pressure, subtle, unspoken, but very real, to move quickly, to sign without pausing, to agree without questioning, to follow the flow of a process that has been designed for efficiency rather than for patient understanding. Most seniors feel that pressure and respond to it the way they have responded to institutional pressure their entire lives, with cooperation, with deference, with a trust in the system that the moment does not have time to verify. And in those first 5 minutes, decisions are made or left unmade that shape everything that follows. Forms are signed that affect legal rights. Status classifications are accepted that determine coverage. The tone of the patient-provider relationship is established, and opportunities that exist only in that window, opportunities to ask questions, to designate a decision-maker, to request specific documentation, quietly close. The families who fare best inside hospital systems are not necessarily the most educated or the most financially sophisticated. They are the families who slow down, who designate one person to handle decisions, who know in advance that the first 5 minutes matter and who have prepared for them before they ever arrive. Edward was 82 years old, a retired judge from Boston, Massachusetts. He was a man who had spent his career ensuring that people understood what they were agreeing to. He was admitted to the hospital after a fall that resulted in a serious fracture. His family was in the waiting area. The registration staff was kind and efficient. And in the first 5 minutes, Edward, frightened, in pain, alone at the registration desk, signed 4 forms without reading them, accepted an observation status classification without asking what it meant, and did not ask for a family member to join him during the intake process. His daughter, an attorney, arrived 20 minutes later. By then, the forms were signed. By then, the status was entered in the system. By then, the window for several important decisions had closed. She said, "My father spent 40 years on the bench, making sure people understood what they were agreeing to. And in the 5 minutes he needed someone to do that for him, there was nobody there. Not because the hospital failed him, because we had not planned for that moment." Edward's stay resulted in complications, a rehabilitation need, and an observation status classification that cost the family $19,000 in denied rehabilitation coverage. His daughter spent 7 months in appeals. She recovered a portion of the costs. She did not recover her father's sense that the system had been fair to him. Here is what every senior and every family needs to do right now, today, before any emergency happens. Designate one person as your hospital admission advocate. This is not your emergency contact. This is specifically the person who will be present at or immediately available during any hospital admission, whose job is to handle the paperwork, ask the status question, slow down the process when needed, and make sure no decision is made in the first 5 minutes that the family has not had a chance to understand. Write that person's name and phone number on a card and keep it in your wallet alongside your insurance cards. When you arrive at a hospital, hand that card to the registration staff and say, "This person is my designated medical advocate. I would like them contacted before I sign any intake paperwork. If that is not possible due to the urgency of my condition, I am requesting that all financial and legal documents be reviewed with them present as soon as they arrive." That statement tells the hospital who is responsible for your paperwork decisions. It creates a record that you requested advocacy, and it gives your designated person standing to review anything that was signed in their absence. Also, prepare a hospital readiness card to keep with your insurance information. On that card, write these 5 questions. Am I being classified as inpatient or observation status? Have all financial and arbitration agreements been identified for separate review? What prior authorizations are needed for any post-hospital care? Who are all the independent providers involved in my care who may bill separately? And what are the specific discharge instructions I need to understand before I leave? Those 5 questions, asked at the right moments, represent the difference between a hospital stay that resolves cleanly and a hospital stay that generates months of financial and emotional aftermath. Before we close, here is your complete hospital protection plan, the exact words for every critical moment. When intake forms are presented, say, "I need 2 minutes to identify any financial responsibility agreement or arbitration agreement before I sign. Can you tell me which forms contain those clauses?" When you are settled into your room, ask, am I currently classified as an inpatient under Medicare Part A or under observation status? And if I am under observation status, what is the clinical reason my condition does not qualify for inpatient admission? Before leaving the hospital, say, before I sign discharge papers, I need someone to walk me through every medication change, every follow-up deadline, every warning sign that requires emergency return, and every activity restriction. Before post-hospital services begin, say, I need written confirmation of the prior authorization status for every service in my discharge plan, and I want to verify coverage and cost sharing with my Medicare plan before my first appointment. At admission, say, this person is my designated medical advocate. I would like them contacted before I sign any intake paperwork. Write these down. Put them in your wallet today. Share them with the family member you are designating as your hospital advocate. Because the moment you need them, you will be inside a hospital. You will be scared, and preparation will be the only thing standing between you and decisions made in 5 minutes that take months to undo. Most seniors who face the situations we have described today are not careless people. They are not uninformed people. They are people who walked into a moment they were not prepared for. You are now prepared. If videos like this help you protect your health, your rights, and your retirement savings, please subscribe and join us. We are here every single week because this information matters and because you deserve to have it before you need it. Because in our next video, we are going back to nursing homes and exposing a trap that families discover only after their loved one is already inside. A trap that does not show up in the brochures, does not come up during the tour, and does not become visible until the family asks a question that most families never know to ask. You will not want to miss it.